Hi, everybody. This is Mina Malapeti with AmplifyMD. Looking forward to another lovely morning chat, this time with Robbins Schrader and our episode of the Seamless Connection. So Robbins Schrader is a co-founder and CEO for SafeRide Health, and I'm excited to have this chance to get together with him this morning. Robbins, welcome to the show.
Thank you for having me. Great to be here.
We're excited to dive in here, but just for the audience that hasn't met you before, can you give them a quick overview of your personal background as well as also of SafeRide?
Sure. Thanks for asking. So I'd say my background from a personal side is unfortunately I lost a friend to addiction. So I've seen how hard it is for folks to navigate chronic care. On a professional side, I'd say I have a largely operations background. So I'm ex-Navy, spent some time on the aviation side, spent 5 years in construction building projects all over the world, which is a ton of fun. Went to business school, then spent 5 years in management consulting, doing sort of turnarounds of family-run businesses and driving more traditional growth strategies. But I do remember being in San Francisco in 2013 and seeing the then startup Lyft and Uber coming on the scene. And I was always fascinated by mobility. And I saw folks solving problems like how do you get to the airport, how do you get a burrito, which turned out to be a huge business. But no one was solving the problem of like, how do you get to care? And so I just kept picking at that and picking at that and picking at that. And then in 2016, came back and jumped all in on building SafeRide, and the rest is history. Nice to meet you.
And are you guys, and I saw a couple things, you guys were formerly based in LA, but now you're in San Antonio, or did I get that wrong?
So we have a large operation in San Antonio. I still live in LA.
Okay. Yeah. So you're still in my home state, so I'll take it.
There you go.
So in terms of like what kind of motivated you, you said you had a personal story in terms of one of your friends passed away. Yeah. Was that related to the mobility issue or just related to, that's what drew you into healthcare in the beginning?
I think it was an early shock to the system to realize like how hard it is for so many folks in this country to access care. And the more we looked at mobility and these new tools coming to serve every other part of our life and this gap in healthcare, the more I was scratching my head and saying, hey, feels like we can do something really great for the community here. Let's start thinking about how we solve this problem of access and apply it to a healthcare lens.
So what is the problem? I mean, so I can guess at a few items of it because I have elderly grandparents who are in their 90s, and I feel like there's a trip to Kaiser every week pretty much at this point. And so right now we're lucky, my family and I we all take turns in taking them in, but I'm guessing a lot of people don't have that same opportunity. So there's like the obvious issues, but just wanted to have you kind of highlight for us, how would you kind of capture the space of mobility driven issues related to healthcare, and how does ride sharing help?
Yeah, it's a great question. So I'd say, foundationally, 60% of our trips are to life-sustaining care. So dialysis, wound care, chemotherapy, and then behavioral health. And the folks that we create access for are folks inside the managed Medicaid programs, and then also the Medicare Advantage program. So folks who are aging into plans, and to your point, you may be in California and your parents are in Ohio and they still need their appointments. Or, hey, you're in Corpus Christi, navigating the challenges of being below the poverty line. There may or may not be bad things around you. And so helping, that single mom make it easy for her kids to get to care is the problem we solve.
So do you allow family members to book rides for their family members, for the other family members, I guess, essentially, in the sense of like, can I book it for my grandparents in another state, like you were just saying, or a parent could book it for their kid if they're still at work, but the kid needs to go somewhere similar to like you do for like, the kids' rides and stuff like that? Or is it more that you're the person who's receiving care themselves, who might or might not be so tech savvy, right, would book it for themselves?
I think you're hitting on one of the first sort of unlocks for us is we realize that, there's the member, but then there's the entire ecosystem that orbits the member: social workers, family members, care navigators on the payer side, the providers who are actually providing the course of care to that member, and then finally the member themselves. And historically, there's been no transparency across all these different touch points. And so we created this technology platform where everyone can basically have agency to engage. And whether you're taking the agency and booking on a mobile app or a social worker is doing it for you, fine. But these are all pathways to solve the same problem of like, let's get Mrs. Smith to care.
Got it. And so how does SafeRide work with the Ubers and Lyfts of the world? I'm guessing you don't have your own driver team, right? You're tapping onto the network that exists already. And how do you engage with them as well as with the health plans to kind of coordinate that whole ecosystem?
Yeah. So I want to make sure I got the question right. So it's basically what is the user journey in terms of how a member engages the benefit?
Yes, that's part of it, but also just in terms of figuring out like are you getting the health plan gives you the patients or the patients reach out to you directly and then you coordinate
Ah,
on behalf of them
got
for
it.
the health plan. Because I'm
Yeah,
sure there's a lot of people that are like, I don't know how to get this, but I need this, right? So
sure. Yeah. So everything in transportation rolls through the plan. So, we serve plans in an exclusive capacity, and then, we for instance serve the Scan Health plan. It's 300,000 covered lives across 5 states, and we basically get all of their eligibility data. And then once we have that eligibility data in our system, then anybody who has that data is able to book a ride. So whether it be the member who is enrolled in the Scan Health plan, who now has a transportation benefit, or again, any of those other constituents who are doing the action on behalf of the member. But everything for the Medicare and Medicaid populations typically starts with the plan funding the benefit and then rolling that benefit out to their membership. What's interesting is the old world used to see this as a cost. And so there's a lot of like, hey, we're going to really contain the benefit and not open it up to the members who need it. In the new world, particularly into these managed care relationships, our clients are fully motivated to have their, that 5% of a population that drives 70% of the plan's total cost comply with their course of care. And so they really want us to drive awareness and help those members who need to access care eliminate that barrier to care.
So your conversations from a client perspective is happening with the health plans and going from there to convincing the health plans that this is a benefit for your patients that is going to help you control cost of care and help you control compliance with care. Is that essentially the conversation you're having from a value proposition perspective?
Absolutely. We hit on 3 foundation metrics. The first is enrollment, the second is retention, and the third is MLR, medical loss ratio. So, and those are pretty headline metrics for a plan. On the enrollment side, we see more and more plans offering the benefit because everyone's seeing that, hey, this works. And now it's a story of, hey, if you have a benefit and the other person does not have a benefit, well, now your plan is more competitive. And so there's a little bit of differentiation. And then also all kinds of really cool things about how you access the benefit, whether it be a digital wallet or, all these other pathways. The second one is the MLR side is making sure that you comply with care. And the third is creating a delightful experience. Unfortunately, transportation there's like the top 2 drivers of grievances are dental and transportation for most plans. And to quote a large integrated system, my 5-star rating is worth $1 billion to me. And so our ability to create this thoughtful, consumer-centric experience that not only one makes the member more likely to comply with care, but 2, lifts up CAP scores and star ratings. I mean, that has a huge impact on a plan's economics.
So then, and you mentioned earlier that not all plans or not a majority of plans even today offer this as a benefit for their members. So what do you think is holding them back?
I think it's time. I think it's relatively new. I think the conversation of SDOH, or social determinants of health, is a relatively new conversation, and now it's being validated. And as more and more data comes out that, hey, these social determinants of health innovations actually create value for the member and for the plan, you see more and more folks rolling it out. So basically, it went from 20% of plans to 30% of plans. Now almost 40% of plans, MA plans, offer the benefit, and we would expect that to clear 50% as early as next year. So there is a pretty rapid growth of folks rolling this out.
That's fantastic. So are you limited at all in terms of only operating in markets where there is an Uber or Lyft to kind of partner with? And I don't know, actually, I shouldn't assume. Are you partnered with them to be the drivers for as you're coordinating these rides, or do you have your own team that does it in situations where that's not an option?
Yeah, good question. So what we offer is we always say we want to offer the right ride to the right member at the right time. And we span a number of modalities. Everything from, hey, you live 50 feet from a bus stop. If we gave you a bus pass, would you go to your doctor's appointment and then use that same pass to get groceries for the rest of the month? If you have a vehicle and we give you a gas card, will that help you get to care? Or often will that help a loved one take you to care, which is actually a fantastic way. It's a very high compliance way of getting someone to care. Then obviously rideshare, Lyft and Uber are fantastic partners. And then what's called NEMT, non-emergency medical transportation. So, for those folks who are navigating dialysis, wound care, these sort of more strenuous courses of care, you may need to have medically qualified transportation taking you to and from, all the way through secure COVID positive transportation. So there's a wide range of modalities, and we operate nationally across the United States. And what we really try to do is think about who's the member, what is their need, and what's the best way for them to get to care.
So if I was calling for a ride, how would I do it?
Great. Yeah. So you would, well, ideally you would open up your phone and be credentialed and you just book it yourself and never have to call. Which is actually really exciting to see, the Medicare population, which historically was not quite as tech savvy, starting to just be like, hey, it's worth me learning how to use this app because I want to get to care myself.
That's amazing. I mean, how many of the population goes through the app versus does the old school way?
It's growing. We're not where we want to be yet, but we've seen some really positive early signal. And that's been really exciting. The other way that it happens more often than not is it's the care navigators. It's, the nurses who have a list of here's the top 15 people I call every week and ask them, are you going to go to care? And in the old world, it was, I'll make it Monday, Wednesday, but Friday, I'm going to drive myself or I'll miss it because, my son picked up a shift at Walmart. And that's when the alarm bells go off at, a big payer, because by Sunday, that member will be in the hospital with fluid buildup. And now in that same exact workflow, they can hit a button and boom, dispatch transportation to get you to care. So it's about empowering the ecosystem. And then obviously you can always call our call center and we'll happily book a ride for you that way. That's sort of the most old school way of doing it. And that will always be a part of what we do. But the more that we deflect and empower the ecosystem, the more we become really that sort of white glove experience for that 15% of the membership who is navigating very serious issues and needs the help, versus just everyone has to go through this old school analog call center experience.
No, that completely makes sense. In terms of empowering the health plans themselves to see the impact, you talked about those 3 key headline metrics for them. Are you tracking that? Are they tracking that? How are you able to show them the impacts of this? Because the more that you show the impacts, I can imagine, just like for us, the hospital system, the more impact you have, the more they want to use you, the more they want to push you to new member kind of opportunities.
I would say you're absolutely right. That is the holy grail. Figuring out how to just tie transportation benefit equals better health outcomes. The challenge is there's so many other covariants in that regression analysis that it's just very tricky to just definitively tie it out. First principles will tell you, hey, if your population is showing up to care, they're going to lead happier and healthier lives. But we're really still struggling on how to thoughtfully articulate that. The other challenge is the sort of historical versus today. You have COVID that hit the last 2 years. And so it's very hard to sort of say like for like comparisons because nothing is like for like in healthcare anymore,
No, it completely makes sense. If you had to look at the entire country and look at kind of where the opportunities lie for improving healthcare options, is it geographically driven at all in terms of whether it's a rural or urban mix, whether there is a coastal versus Midwest mix, whether it's, I'm just trying to understand if it's from the hospital perspective and the specialty perspective, which is my background, or with AmplifyMD, we see a huge difference, right? Based on geographies and based on clinical setting. I'm wondering if you're seeing the same.
We are. So what we're seeing is the rural markets have always really struggled with access issues. And you see it also like the hospital groups, just getting physicians into rural markets is also hard. But, that continues through to, in a market where there is no ride share, then your only option is NEMT, and you really have to make sure that you're thoughtfully engaging and building out networks to give a lot of latency. What's more interesting is creating the ability for populations to move across the grid, so to say. So we'll go into a market like North Carolina where you've got, Wake County and, all the UNC health systems there that are like, world class. And then you have Johnston County, which is way out in Eastern North Carolina. And so helping folks in Johnston County seamlessly access Wake County and vice versa, has been really exciting for us.
And do you do any of that? I know you're focused on the transportation to get them there physically. How much does telehealth play a role, if at all, with that in terms of helping patients manage that if they can't get there versus getting them there when they can, right? In terms of plugging the gaps to still at the overall reduce costs for your ultimate client.
So this is something that I've been talking about for a bit with the team. What we're becoming is effectively the infrastructure for the entire market. We have this layer that can snap into any number of points of access. And, the way our CRO explains it is we want to bring transportation closer to the point of need identification. So whether it's you identify the need, or dialysis clinic identifies the need, or, a social worker who's talking to you identifies the need, they need to be empowered. But what we're seeing is, to your point, healthcare has totally changed in the last 18 months. So you have telehealth, home health, and brick and mortar. And right now they're totally siloed, which makes no sense because it's the same members spanning that continuum. And so, we see, for instance, you go to a telehealth appointment, a rash isn't so good, and someone says, hey, you got to go see somebody. Right now there's no way for that person to seamlessly access brick and mortar. Same with home health, which is more pronounced. Like, folks will go do a visit, the member won't be looking good, clammy, non-responsive, and they're going to say, hey, right now you need to get to brick and mortar, but the only option is 911, $2,000 ambulance, $10,000 ER admission, versus hit a button, $50 NEMT, visit your PCP, have a great experience, go home to your bed that night. And so we think there's a real opportunity to bring home health, telehealth, and brick and mortar together, and we're pretty excited to do that.
It's fantastic. And then we talked a little bit, actually talked a lot about how the patients are getting access to care and bringing them to the point of care. Is there an opportunity there on the flip side, right? Bringing the doctors to wherever it is, and not necessarily individual house calls. That's not nearly as efficient as it ever was, I think. But in areas where there are lots of elderly, for example, LTAC, SNFs, assisted living, is that an area where you could flip it the other way and say, we can help you, health plan X, bring physicians there to reduce the cost of care for this facility or this patient population?
So unlocking bidirectional movement of not only patients to brick and mortar, but brick and mortar to patients. Yeah, absolutely. There's opportunity there. I think for us, we see so much opportunity on the bringing folks to brick and mortar that, we're just really focused on delightfully solving that problem. But to the extent folks then say, hey, now we want to go the other way, I could see that making a ton of sense.
Awesome. So what are you working on next in that case?
There's
tons of room to grow in terms of like bringing the patients in. I mean, because from a telehealth perspective, it's easy because we can beam in or they can beam into us. And there's that extra challenge you've kind of thrown yourself in terms of adding in the transport part of it and bringing the bricks and mortar part of it. So I'm curious to see, like, what do you think is important to tackle next, and what do you kind of envision over the next 3 to 5 years?
So I think for us, we've been fortunate to grow so quickly that I sort of speak about automation, integration, and security. Those are the 3 key pillars. So when we think about automation, we're going to a place where we're doing thousands and thousands of rides every day. Mm-hmm. And we need to create these pathways where our algorithms understand members, they understand the reliability by zip code, by hour of day. They just are able to remove any human interaction because at a certain point, like, the cognitive load is too great. And so using the digital exhaust of, millions of rides to power our algorithms is a big focus of ours. Once we have this fully automated, hyper accurate sort of engine, then it's about integrating it into our partners. And so whether you're a home health company, whether you're a telehealth company, whether you're a payer and you have a digital wallet solution, or you have an EMR that you want to access healthcare inside of, like, we are creating these pathways to be totally agnostic to how you want to access this tool, but we just want it to be available to you in the pathway that works for you. And then security, we are wrapping up high trust, but that's just the start. I think there's security that spans both the member experience, the network compliance experience, then also just the underlying tech infrastructure, and that will never go away.
Yep, no, that makes complete sense. And then bringing up security, so looking beyond the tech for a second, how do you ensure security and safety for the patient and ensure that 5-star ride? So part of it is just getting them to where they need to be on time. Yeah. But the other part is, like you mentioned, the non-emergency medical transport, or if something does happen, God forbid, while they're on the ride to the doctor. Have you ever run into situations like that, and how are those handled?
Yeah. So I'd say security is paramount. It's like the defining part of our industry and our name right now is SafeRide. So we take security very seriously. I think it comes back to first data. So understanding, hey, this is a member, it's their first time ever experiencing rideshare in their life.
Mm-hmm.
Like, let's take them on a journey and educate them properly about this is what rideshare is, this is how it works, and get them comfortable with the experience. And then it goes great from that point forward. Similarly, our algorithms thinking about, who's in a van at what time, the needs of the member. Oh, I need a Spanish-speaking driver who's female because unfortunately I'm a victim of domestic abuse. Mm-hmm. So just thinking very, very carefully about the needs of the member and educating them has really helped us deliver this experience that really puts their safety and their experience at the forefront of the experience.
And as they're kind of seamlessly getting used to this new process and kind of connecting it, do you tend to have repeat customers? Because a lot of these issues that you mentioned are chronic conditions, right? The dialysis, et cetera. Wound care. Is this something that you can kind of set and repeat? Be like, hey, Monday, Wednesday, Friday at 3:00, I'm picking up Mr. Smith, right? Or Mr. Smith, it knows that I need to book this ride forever for like the next X years. How does that repeatability work versus kind of one-off patients, which I think might or might not be, I guess, harder for you guys to include in that?
Yeah, there's two cohorts. So I'd say, 60% of our volume is life-sustaining care. That's typically a recurring course of care: chemotherapy, wound care, dialysis. And so these folks, get to know their drivers very well, their routes really well, and they build a rapport. And so that works out quite well. And there's all kinds of like gotchas, like, oh, drop off at the back door, not the front door of this clinic, or, it's endless. But we capture all that. And then once you get it right, mm-hmm. then it just sort of runs. And in fact, when we think about onboarding new clients, if Mrs. Smith likes driver Joe, who used to serve her, who was part of a different program, our algorithms will say, okay, well, let's make sure that driver Joe is the one who picks you up when you join the SafeRide program. So creating that continuity is really, really important. Sorry, what was the second part of the question?
And then when you have like the one-offs, right? So not the ones that.
Thank you. Yes. So then, the biggest problem is this industry has not allowed same-day transportation, mm-hmm. which is crazy. And so there's this, mantra of, 3 days pre-booking requirements, and has to go through a call center, which is not a great experience, and so these folks who need to see a doctor urgently are left with the recourse that no one wants, which is 911, $2,000 ambulance, or I just don't go.
Yeah.
And so roughly 20% of our volume every day is same day volume, and our ability to pick that up and solve that problem creates enormous value for our partners.
Got it. And then from the PCP perspective, because I know you guys have a huge impact on no-show rates, right? So obviously the health plans are benefiting, the patients are benefiting with better compliance and better health outcomes on that respect. But from the physician perspective that you're taking them to be seen, are they excited? Like, what's their response to this in terms of getting the patients in? If you're able to impact their no-show rates, you're able to get them patients in or compliant that weren't before. How does that relationship work, given that they're not a direct kind of member of the contract, if you will, of that kind of two-way contract, but they're a direct beneficiary?
Sure. I mean, providers are fantastic partners. And we actually started selling to providers first before we sort of built the compliance infrastructure to take the next step into the payers. Okay. So our DNA is we started with the providers, and we serve both national dialysis providers nationally, in addition to, regional health systems and things of that nature. I think, they're the tip of the spear, and they're dealing with extraordinary challenges, and having folks show up reliability to their procedures when they're, you have a hyperbaric wound chamber, it's a very expensive piece of equipment. And if people don't show up, it's just really hard to run your day-to-day operations.
Yeah. I mean, think about just like with infusion clinics, same thing, right? Which is you're prepped for those infusions, and you need to have the oversight and the supervision. And if someone's late, even if it's 20 minutes versus a no-show entirely, that can throw off the entire day as well.
But I'd say across all providers, there's this element of fee-for-service provider experiences are sort of moving further and further to the wayside, and there's more and more shared risk relationships. So the more a provider starts to behave like a payer, mm-hmm. the more they're incentivized to sort of take action, because now they've got some skin in the game to make sure this works.
No, that makes sense. And how about for you guys? Are you interested in going the value-based, risk-based angle?
We are typically cost plus, but from time to time we will engage in what we call PMPM contracts. But what we do is we typically build our contracts in a way where we really think about who are the members and what is the desired experience for those members versus just monolithically spreading, X rides across the entire population. And then we're able to have a conversation in historically a PMPM relationship that didn't work to say, hey, we really want these populations to get to care, and that's going to be roughly these many rides. And, wellness visits are great, but you only need like 2 a year,
Yeah, no, that's true. And then to kind of understand how it works with kicking off a new client, I'm guessing, and did you, I don't know if I got this, where are you kind of geographically focused now? Are you nationwide? Are you mostly West Coast, Midwest?
We're nationwide,
Okay.
but we have a core market strategy where, we have around 16 markets with substantial volume in them. And, as you thicken a market, you're running numerous MA plans, Medicaid plans, and provider programs in the same ecosystem. It gets easier and easier as you get density in the market.
Right. And that's what I was going to ask you in terms of, we see similar things in the hospital setting where, once you start providing one service, it's a lot easier to get the second, third, fourth service going. So similar for you guys when you're breaking into a new market though, right? And no one, you have to kind of prove it all over again, if you will, or kind of earn that with the patients and with the client. How do you go about doing that in kind of the secret sauce way, if you will? Because you've done it now so many times. Have you found that it gets easier, or is it still kind of you still have to prove yourself every single time?
Oh, we were really good at making mistakes. Well, the good news is we learned from those mistakes. So yeah, we definitely didn't get all of them right the first time. No, I think when you think about our growth strategy, there's a core market philosophy of like, once I'm operating in Texas, dropping an additional incremental revenue in Texas is one, immediately accretive, and two, dead simple, because all the pipes are connected and then everything is just set up and ready to go. Whether it's the encounters data, the claims data, everything is just set. We also have a core market strategy. A core client strategy. So, we have worked with a large integrated system. We've expanded them 6 times across now 3 regions. And so they'll say, hey, we know how you work in this region. Could you go ahead and open up this region for us? And then we come with an anchor client who knows how we operate. And so you have that trust to sort of build up the market around them.
Yeah. That's fantastic. And do you find that word of mouth and referral growth is the best way? I imagine with payers, it's a little bit different, a little bit harder to expand into new clients, not just new geographies with the client. What's the kind of your plan and your going forward outlook on that front in terms of attracting new clients, whether they're similar MA plans that you're not in or a completely different kind of clientele that you see opportunity at?
I think we try to be really focused on the markets we serve for all the reasons we just shared. I would say the other thing is healthcare is concentrated. So we sell to over 50% of the U.S. Medicare market already with the clients we have, and so we shamelessly overserve them, and we invest a lot in making that relationship a great relationship so that we can do exactly that. The good news is transportation is very data driven. So there are very clear metrics that you can say, this is the member experience, this is the fulfillment rate, this is the no-show rate. And so people can, just use data to say, okay, this is or is not working. And more often than not, people are saying, yeah, this is working. So let's do more of it.
That's fantastic. If you could have one thing change on the regulatory framework for next year, because I've heard this from everyone in a lot of ways. Is there anything that you feel like is holding you back or that you would change to open this up, whether it's for you directly or for your segment of the market overall?
I would say Medicare scales a lot faster than Medicaid. It is more tech forward because there's less restrictions. And so we're driving really interesting innovations around the member experience, how you access things, using AI to really create a better experience in MA. We are now harvesting that data to then go and work with the Medicaid market to say, hey, this works. We should think about deploying these innovations. And I think the Medicaid regulators are really excited about new and better and different. It's just harder to navigate 50 different Medicaid agencies versus a more monolithic Medicare backdrop.
Yeah. Well, also, Medicaid obviously never quite pays the same way. And so how much of that is, and will they match what Medicare will do for certain benefits like this as opposed to kind of professional fees?
Actually, the interesting thing is 100% of Medicaid has a transportation benefit.
Oh,
It has since 1965. Yes.
really?
Yeah.
That's crazy.
So they were, first to really be the innovators, and
Yeah.
Medicaid, has been, driving this benefit forward. Now, the way it's been delivered has changed quite a bit. It used to be delivered through large state contracts. So state of
Mhm.
Kentucky rolls out, the transportation benefit. Now it's,
Yeah.
Molina or Centene
Yeah.
or Ameri Health, the operators themselves are taking the benefit in house and they're driving a new solution because they have the agency to tweak things as they see fit. And they're totally invested in doing it right because it's their membership that they're serving.
Got it. So in the states where you talked about the 16 core markets, is that areas where you've done Medicare and Medicaid, given that you have kind of that the heavyweight presence in that geography already? Or is that still an expansion area for you guys to
Those
switch?
are expansion areas. So we have a lot more Medicare
Mhm.
coverage across the United States. Medicaid, it's a major investment and highly complex. And so
Okay.
we have a couple key Medicaid markets that track to the largest markets in the United States.
Yeah.
So
Well, no,
that's what I'm
the
thinking
fact that
about.
you're even attacking it is props because I know how complicated Medicaid is to work with from a physician and a profi perspective. So I can only imagine on the ancillary benefits how complex the rules and regulations must be.
But it's exciting because the Medicaid population, that's where the need is the most pronounced.
Right. Exactly.
And helping foster kids get to care. I have a 3-year-old. I'm a dad.
Mhm.
It just feels good.
Yeah.
So I really enjoy the challenges that we're running through because that means we're building a better solution for this population.
That's fantastic. Do you have any last words for our audience here? I'd love to make sure that they walk away from this understanding just how seamless you're making it to get people to care and access care wherever they are, and regardless of their transportation condition.
I would leave with maybe a note of optimism. I really do think that the future is pretty bright in terms of where healthcare is evolving. And this idea of we saw these new things really become established, telehealth and home health in the last 24 months, relatively new things. Like now we're going to start connecting these things together, and I'm really excited to see what that world looks like.
Same here. I can't wait to see what comes next. Thank you so much for your time this morning.
It was a pleasure. Thank you.